Hello and welcome to this virtual launch event for the Act Now report into the ARMA inquiry into MSK and health inequalities. My name's Sue Brown, and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA, which is an umbrella body that brings together patient and professional organisations to work for better MSK services for people with MSK conditions. Before we start, just to note that we are recording this event during a pre-election period. Unfortunately, that means that Leslie Kay, who is currently the National Clinical Director for MSK at NHS England, is not able to join us because of NHS England's guidance on pre-election periods. But she was very keen to attend, and she sends her apologies and will be watching this discussion with interest. And we'll no doubt have an opportunity to hear her reflections on it at a later date. For similar reasons, today we're going to focus very much on what local services and actions local services can take in order to address MSK health inequalities. Financial support for the inquiry was provided through sponsorship from Rheumatologist UK Limited and charitable grants from Pfizer Limited, Novartis Pharmaceuticals and Janssen. And before I invite the panel to share their views, I just want to give a quick overview of the project and the report. So we gathered evidence through a literature search and some calls for written evidence. We also held 4 oral evidence sessions, all of which are the recordings of all of which are available through our website. And we were also advised by an expert panel made up of experts in health inequalities, and throughout the project by a lived experience panel, one of whom is on our panel today. The facts about MSK and health inequalities are pretty well known and well established. In the least deprived areas of England, Scotland and Wales, between 12 and 14% of people report having a long-term MSK condition. In the most deprived areas, that is between 20 and 26%. So in Scotland, the rate is actually double in the most deprived areas. There is nothing different about the people who live in deprived areas. This is not something that is about a genetic difference. All of this additional MSK is preventable. And that's really why we wanted to focus on deprivation. And we wanted to look at the underlying causes and some of the things that could be done to reduce these inequalities. So we identified some of the key drivers of inequalities in MSK health. So we looked at poverty and some of the ways in which people living in poverty struggle to access health services. Poor employment has a big impact on MSK health, and lack of employment. We all know that good work is good for health. And lack of education, which can tip on into lack of health literacy, and in some cases also digital literacy as an issue. And then we identified 2 key modifiable risk factors. So one of those is physical activity. Pre-pandemic, we had 58% of people were deemed to be physically active in deprived areas, and that figure was 67% in the least deprived. During the pandemic, both rates across the board went down. Post-pandemic, the least deprived areas have recovered the levels of physical activity. The most deprived areas still have not recovered to the pre-pandemic levels of activity. And then the other issue is around healthy weight and healthy diet. And again, we see numbers of people living with obesity in more deprived areas compared to less deprived areas. There are some quite dramatic differences. And none of those modifiable risk factors are about lack of willpower or personal commitment to your health. People in more deprived areas are living in an environment and surrounded by a food culture that deters physical activity and makes it more difficult to eat a healthy diet. So we know that only 20% of our health is driven by healthcare, but there is still a lot that health services can do to tackle some of these inequalities. And we pulled out some key themes. So we pulled out things like knowing your community better, developing shared ownership of services through patient involvement and co-production, using data to identify how best to tackle things. And key is avoiding inertia. The scale of the problem is quite large. It's more important to start somewhere in the spirit of quality improvement than to wait for the perfect. And then some other key messages. There are some particular challenges around paediatric services. The importance of targeting intensive, tailored, supportive self-management to the people who most need it. And I would hugely recommend the oral evidence session we did on supported self-management, which was excellent. Recognizing the impact of living with multiple long-term conditions. People in more deprived areas have more long-term conditions and develop them at an earlier age than those in least deprived areas. And that makes a significant difference to their ability to manage their health. And finally, the critical importance of the quality of clinical encounters in addressing some of these issues. So before I invite our panel to comment, we've got another quick Menti poll, if Kathy would like to load that up. And it's really just a quick question. How would you describe the Act Now report in as far as what you know about it, whether you've read it or whether you've just listened to my summary? How would you describe that in 1 or 2 questions? So again, you should have the invitation to open Menti, and we'll just give it a minute or 2 for people to respond to that if they wish. And just a note that Menti responses are all anonymous, so you can happily write whatever you like. We've got golden opportunity, broad in scope, shocking, thorough, glad to hear, comprehensive, predictable, agenda setting, bold. There's quite a lot of different reactions to it. But we've certainly had a lot of very positive reactions to it. So you can carry on posting in that, but I'm going to ask Kathy to take down the screen so that I can introduce our first panel member. So Anthony Gilbert is a postdoctoral clinical research physiotherapist at the Royal National Orthopaedic Hospital. And he's been involved in a project that's been trying to address some of these issues within his local service. So I'm just going to ask Anthony if you could just tell us a little bit about what you did, how you did it, and why.
Okay, thanks for that, Sue. I'll try and be brief to keep the discussion going. But what I intend to do is to describe something that we've been doing in my local service. So I work at the Royal National Orthopaedic Hospital, and in partnership with Royal Free London, we established a musculoskeletal hub in a place called Edmonton, in Enfield, which is a borough in London. Enfield is regarded as one of the more deprived boroughs in London, and Edmonton is particularly deprived. And when we set up a musculoskeletal hub there, we intended to cater for the local population. We run FCP clinics through the Royal Free, and we had certain expectations that people would be coming in to access physiotherapy services for their musculoskeletal problem. And what we found, so I'm attached to the project as a researcher, and what we found just looking through the routine data that we collected, we identified that the people that were coming through weren't as deprived as the sort of average demographics of the local population. And what we inferred from that was that those most deprived in this local area weren't coming to access our services. We did a huge amount of engagement with local communities and community leaders, and what we what we decided to do through building up strong relationships with one particular local leader was we went out and we started to do outreach and education clinics in local food banks. There's a huge network of organisations working together across Enfield to tackle food poverty, and we started off by doing some volunteering in local food banks. We established an outreach clinic where people who were accessing the local food banks who had musculoskeletal problems, we were then able, providing they had an Enfield GP, we were then able to signpost them into our clinic. We established an outreach clinic for these people to come in, and then we're able to deliver sort of free at the point of care musculoskeletal care through our outreach clinic. And I suppose the key things that we recognise as a team is that the people who are experiencing poverty, and in particular food poverty, have got set priorities in their day-to-day lives that they need to focus on. So getting food in their bellies, bringing in money to provide them with shelter and with housing, and healthcare actually was a reduced priority for them through having these conversations. And we recognise that there are preconditions that people need to have in their lives in order to be able to access healthcare. So we've now seen just over 100 people in our outreach clinics. We're looking to expand beyond food poverty organisations. We've got meetings set up soon with immigration centres, homeless shelter. We've expanded to other food banks. We've done some work and some engagement with local religious communities. And we've just been awarded a research grant to do an in-depth research investigation into the challenges that people from deprived communities face when accessing healthcare. And this is in collaboration with UCL and Keele University. And what I would say is it's not, we're doing some work in this area. It's not just a one thing that you can drop in, it's a process, and there's a huge amount of work that goes into it. So we've got some insights in working with these quite deprived populations and deprived communities, and we're getting some insights into the challenges that these people face. But I think it takes a huge collective effort across professions, across organisations, and I'm really thrilled to be able to contribute to the case study towards the ARMA report. And I think it's a fantastic thing that we're doing, coming together and having these conversations, because it really shines a spotlight on some of the challenges these people face. So I'll stop there. 4 minutes. I'll stop there. I don't want to take any more time, but I'm really happy to take any questions later on.
Brilliant. Thanks, Anthony. And I'm sure there will be questions for you. And I think Anthony's case study was a superb description of how the steps you went through to identify the community and then to reach out to them and then to think about what the solution was. I know this is not the only example, and in fact I know of examples that have heard about the work you did and have then done the same process with their own services and have come up with a different community that they need to reach out to, but the process has been the same. So really brilliant to hear that, and no doubt people will have further questions. But now I want to bring in Shabir. So Shabir Aziz was a member of our lived experience panel for the project. And Shabir, a lot of the evidence that we got talked about the importance of co-production and involving communities and involving lived experience in the work. Can you say a bit about why you think that is so important?
Thank you, Sue. Firstly, I'd just like to say it's been a great privilege and pleasure to be a part of the ACNAR report, not just because it raises some important questions and relevant issues with regards to MSK health inequalities, but also because many of these issues reflect my own personal journey living and coping with MSK conditions, as well as dealing with some of the fallout, the social and economic fallout of having such conditions. To give a little context, in particular in terms of lived experience and patient involvement, I think just a little background would be useful. So I'm of British Pakistani background, and I was born and brought up in the east end of Sheffield, which is a steel manufacturing city traditionally. But in the 80s, all that kind of closed down, and that led to a kind of massive kind of decline in work in the area. and lots of people were made redundant, including my father and a lot of my kind of family members. The East End of Sheffield is still predominantly working class today and quite diverse ethnically. But unfortunately, it's also a victim of the economic downturn, which I mentioned. And now this particular area now suffers multiple levels of socio-economic deprivation. It's in the top 20% of the most deprived areas, according to the English indices of deprivation. And in terms of health inequalities, it's in the top 10%. So it's against this backdrop that my own personal MSK journey began almost 30 years ago. And with that, the challenges of holding down a job, raising a young family became much more difficult. So my apologies if that comes off across as a little depressing. But the reason why I mentioned it is perhaps a journey that's reflective of many other people who may live in similarly deprived areas across the country, who may be of a particular ethnicity and suffer consistent health issues, including MSK issues, and have a massive reduction in the quality of their life as well as that of their families. Furthermore, their experiences of coping with the NHS services, like my own, may be vastly different to those from more affluent areas. So it's these experiences for me that made it vitally important to find ways of getting involved in health equity research, policy and services in order to try and make positive impacts for neighborhoods like mine and for people like me. Uh, I've, what I'm going to do is just give a few examples of the kind of things that I've done just to kind of crystallize it and things that I'm doing in terms of using my lived experiences to inform health services. So, I mean, first of all, I have to mention that I come across a lot of people that are quite negative about giving lived experiences because they often think that it's a little bit idealistic, unrealistic, and even kind of tokenistic. But I have to say that's not been my experience so far. Uh, the first example is I have to mention is my collaboration with as a lived experience member with ARMA in terms of the Act Now report. This experience has not only educated me about some of the more complex issues around MSK health inequalities, but it's also allowed me to reflect and feedback some of my own experiences, questions, and challenges. For me, the recommendations of the report uh, can potentially make some genuine changes in MSK patients like myself from deprived backgrounds. Secondly, I've also had the opportunity to be featured in a co-produced video with a charity called NAS, that's National Axial Spondyloarthritis Society. And the purpose of that was to highlight the economic impact of having a delayed diagnosis of an MSK condition. My own diagnosis was delayed for over 10 years. And it's really important that early diagnosis is made for all MSK patients in order to be effective, to give effective help and treatment before long-term damage sets in, which again was a situation in my case. Thirdly, I've been asked by a local health and wellbeing organisation, which draws down much of the funding in my area to tackle health inequalities, to submit some articles on health and inequality, and which includes one on arthritis, deprivation, and the importance of self-management. That same organization recently asked me to become a board member, a trustee, and with the aim in mind to strategically design and drive measures against health inequalities in my local area. And what I had in mind was, in particular, to highlight the MSK issues and inequalities in my local area. And finally, I serve as a remote peer mentor for another MSK research project for people with osteoarthritis. And this involves meeting regularly with people online in order to share my own lived experiences of managing arthritis and some of the challenges around that. And the hope in that project is to motivate these patients to improve management of their osteoarthritis. Hopefully, these serve as examples of the importance of patient involvement and how using one's own lived experiences can potentially impact and influence positive and beneficial change for those affected by MSK health inequalities in deprived areas, both locally and nationally. They also, I think, directly and indirectly uh, linked to some of the issues and proposed solutions by the ACNOW report in terms of tackling MSK health inequalities. For example, the importance of taking MSK services into the community where they are more accessible and more locally sensitive. Ultimately for me, co-production, providing lived experiences has to be about creatively and effectively engaging those people who are directly affected by MSK health inequalities in deprived neighborhoods, and then taking those ideas for tackling them from there. Thanks for listening.
Thank you very much, Shabir. And I can say that the lived experience panel of this project certainly made a big difference on what is the content of the report. And everybody, I mean, yes, co-production can be tokenistic, but everybody that I've ever spoken to from a professional perspective who has done it not in a not tokenistic way has said how valuable it's been, how valuable those insights are, and what a difference it makes. And certainly I was mentioning there are services that have taken Anthony's process and gone through with it. Well, one of those that I was speaking to a few months ago, there's no way they could have guessed what the issue was for the community without reaching out and talking to them and finding out what the actual barrier was, as opposed to them attempting to second guess what it was. So I think it is a really important part of the report, the importance of that. Another thing that was really important to us was to make sure that we covered all ages and that we included children and young people who face specific issues, and paediatric services face specific issues. So we did an oral evidence session on this, which Jacqui was kind enough to join and give oral evidence. So I'd now just like to introduce Jacqui Clinch, who is a consultant paediatric rheumatologist. And Jacqui, what do you think are some of the specific challenges that are faced by paediatric services in tackling these inequalities in relation to children and young people?
Thanks, Sue. Thanks, Shabir. First of all, I totally agree with Sue that lived experience is the narrative to all the work that we do going forward, and I'd say central. So there are many other areas with children and young people that are, I wouldn't say more difficult, but different challenges to those experienced by adults and older adults with musculoskeletal problems. Deprivation is a cross-cutting theme for all of us. Peri-pandemic, through the pandemic, and particularly after the pandemic, that has, if anything, increased the challenge that we face. To give you maybe an example of a patient journey, I'm in Bristol. I serve young people across the southwest with musculoskeletal conditions. Colleagues of mine in tertiary, so large hospital settings in the UK, have a similar large outreach session. The furthest someone travels to me is from Cornwall to Bristol, which is around about a 4-hour journey. If you are in Cornwall, where deprivation levels are high, rural deprivation, particularly in the southwest, is a problem. Then many young people cannot make that journey because they're dependent on their carer to bring them to outpatients. So the young people that are unable to make our appointments are as needy as those who are able to make them, but their social circumstance and their geographical circumstance means they're unable to access the care that they require. So immediately there's an inequity of access. There's a deprivation with being able to be an advocate for themselves. So many adults have a degree of advocacy. They can take their problems to their physician or their health professionals. Young people, by definition, don't have that. And so to give these young people a voice is very important going forward. Education is key. We know during COVID, a whole generation of young people missed out on education. A substantial number of those young people are still not accessing education or have missed out completely. If you have a chronic disease like an arthritis or musculoskeletal pain, then that further hampers your chances of employment and general well-being as a young adult. If we get it right in young people, then the young adult life is smoother and more fulfilling. Mental well-being of young people is a huge area that many of our patient partners have looked at with us, and that bit of work is continuing. You'll know from the press that mental health in young people is getting worse, and that affects their physical well-being as well as their emotional well-being, and again how they transition into young adult life. The other key area, as I've just mentioned, is transition. If we are able to smooth out the journey between paediatric input by paediatric health professionals and that provided by young adult health professionals, and we get it right between the age of 16 and 25, when young people are very vulnerable. If we can get that right, then we can really move forward in leaps and bounds as a society. Another area that maybe I'd like to touch on is people's awareness of young people's musculoskeletal conditions. Many large parts of society have never heard of children getting arthritis or musculoskeletal pain. And I think we, from this excellent report, are very positive, and I would say collaborative approach we can do to go forward is really increase societal awareness of child musculoskeletal conditions and the impact, because we could really make large strides in that. So with looking at solutions, and I know we've discussed this many times, and that's why I'm delighted the report's out, and I'm delighted that we've got so many people involved. Data is key. It's really difficult to move forward without data, and I'm delighted to say that we've secured a GIRF to get it right first time, where we're really deep diving, or colleagues of mine are really deep diving into the data we do have around young people's musculoskeletal health, both inflammatory with arthritis and importantly non-inflammatory. We're looking, just as Shabir was saying, about the local hub. How can we get young people not having to travel 4 hours from Cornwall? How can we get their MSK needs met in the majority more locally, in leisure centres, in school settings, in settings where actually not only is it physically easier to get to, but there's also a social acceptance. It's very difficult to be a 14-year-old boy with an arthritis or a musculoskeletal pain and keep having to go outside a normal setting to get care. Having it in a leisure centre or school setting would be fantastic, and we do that collaboratively. Looking at mental health well-being in young people, this is a big thing at the moment generally, and how can we do that from our collective kind of within this report? How can we advise people? Transition services, again, we're very much looking at that collaboratively. How can we make that a smoother journey across different health professional and community areas? We did produce, you and I are involved, and others maybe on this call were involved on working to have an education or a literature for government, for schools and for universities and for employers of young adults about how to help them. So that's a very small step in improving transition services. So yes, lots of challenges, but I would hope lots of collaborative solutions.
Fantastic, thank you. Certainly there are recommendations related to paediatric services that I've already had people come and say, this is the one for our service, we're going to try and implement this one. So those who describe the report as overwhelming and broad and so on are absolutely right. But I think that key message about just don't be overwhelmed by this, find the one thing in there that you can act on and act on that. Before we go into a discussion based on the questions that people have posted in the Q&A, I am going to invite you to answer another poll, which Kathy will share. And the question is, are there actionable steps that you can take in your role to tackle MSK inequalities? So what are the actionable steps that you can take? And Kathy, I don't think that presentation has opened on the screen. Might need opening again, but you should be able to access the Mentee and start to respond to that question. So remember, this is anonymous, so you can put what you like. No one is going to hold you to it. Are there steps that you could take? Any thoughts? There we go. So we've got lots of yeses, some maybes. Nice to know there's no no's. Okay, so lots of yeses and some maybes. So we can maybe talk a little bit about some of the practicalities of this, perhaps shift some of the maybes into the yes category. So Kathy, if you want to stop sharing that one, and we will now start to talk about some of the things that have come up. I'm going to start with a very specific question for Anthony, and we may want a broader discussion around it. So it's, was your food bank project funded? It might feel like quite a big piece of work for services you don't have any additional funding or resource. Do you or any other members of the panel have any ideas on more small scale ideas that can help to get people started? So I'll start with Anthony and then bring the others in.
So the food bank project itself wasn't sort of explicitly funded, but it was part of an overall program of work around establishing, well, doing some orthopaedic backlog clinics to help clear the orthopaedic backlog in north central London, and around setting up the musculoskeletal hub. But what I would say is, through the funding for the overall project, some of which was received from the ICB, some of which was received by the Royal National Orthopaedic Hospital and the Royal Free, we had a huge amount of organisational support to be able to go and do this project. So although there wasn't funding directly provided to do this, when we identified this as a challenge, that we weren't seeing the people from deprived areas that we expected to, we were given license to be able to explore this in more detail. We had some fantastic engagement conversations and workshops with people that, again, was supported by our organisation. And I think that's to be mandated to crack on and to try and solve the problem by the chief executive of the organisation and by our director of allied health professions was incredibly helpful. I think, you know, some of what we've done, we've managed to generate some smaller funding. For instance, a large proportion of people that attend the food bank are Turkish, so we were able to get some leaflets and some information sheets translated. That cost money, so we're able to get some funding for that. We've had pop-up banners translated as well that we take down to the food banks that say things like, have you got a muscle or bone or joint problem? Come and speak to a member of our team today. We've got those in different languages. That obviously did cost some money, not a huge amount, but there are small things that can be done like that, which can make a big difference. And I think through, you know, these smaller things, what we've now done is we've reached out and we've established a relationship with a Turkish and Kurdish charity in the local area. We recognise that, you know, I'm not Turkish. I'm not from Turkey. I'm from England. But we recognise there are cultural differences there, and to have an organisation based within our musculoskeletal hub where Turkish and Kurdish community come into and speak to them and use their services on site when they identify that there is a musculoskeletal hub with clinicians that can see them, and they can see them straight away through our outreach clinic, then actually we get that crossover with community services and also musculoskeletal services. So we've really brainstormed and tried to think, I suppose, innovatively, how can we try and bring some of these communities closer together? How can we get the throughput? How can we get the footfall coming into our hub? So then we've got an opportunity to be able to reach out and speak to people which wouldn't necessarily come into a musculoskeletal clinic. And I think what we found is that what healthcare looks like for different communities isn't necessarily first contact practitioners in a GP clinic, and actually what that looks like is walking into an accident emergency down the road. So we're trying to do as much as we can to engage with these different communities. So in answer to the question, yes, there was funding provided that enabled us to do this. I'm funded as part of this project. I don't hold down a clinical caseload. I have the time to be able to pivot and respond to all of these different things and liaise with the clinical team, etc., etc. So that was definitely the catalyst for it. But some of the, I suppose, more meaningful projects that we've been able to extend on from this haven't required a huge amount of funding. But you do need that. You do need that organisational support to be able to do it.
Yes, and I can say I've spoken to people who have done something very similar, but I don't think they have had specific funding for it. But what they have had is that organisational support. So if we've got anyone in a more senior position on the call, there's an immediate answer to the question, what can you do to support this work? Jacqui, did you want to come in and
just
perspective?
Well, yeah, just from a general perspective, really, there are many pockets of excellent practice around the UK where people have been very innovative, and departments have been very innovative, secured funds from different streams, and come out with some really fantastic outcomes. A very worthwhile thing for us all to do is look at all these areas of best practice, because if we are able to show areas of best practice, we don't necessarily need to replicate them in our own area. We just need to show it to fund holders. I'm not going to get political, but because the data's there. And I worry that we'll all be trying to do things in our own areas when actually there's really good best practice. For example, in Sheffield, they do all their transition clinics in a leisure centre. Their attendance is almost 100%, and the young people are positive and go to the leisure centre at the same time. And so I'm not going to replicate that in the Southwest. What I do is then say, look, here's the data from there. So I think, Sue, we have an opportunity here to really collect all of this best practice, like Anthony's been talking about, that has been funded through different streams, and use that data.
Thanks, Jacqui. And Shabir, did you have anything to add on this one?
No, sorry.
That's okay. Not a problem. Brilliant. And as I say, people have used the initial stages of Anthony's process of identifying your key target audience, and then it comes up with different communities and different types of solution. So they won't necessarily all be exactly the same in size and scale, but some of them I know were really quite straightforward and short. But yeah, we do understand the challenged situation everybody's working in, and that funding can be quite a challenge. But also ICBs all have a health inequalities lead at quite a senior level, a lot of whom would be really interested to hear what the MSK services want to do. It's worth contacting them as well if you've got ideas. So we've had a couple of questions. Oh, sorry. Did you?
Sorry, I just wanted to make another observation as well. I mean, one of the things that really worked for us, we didn't start this all up just ourselves. There were already, and there are, and I'm sure across all areas of the country, there are existing sort of communities, charities, organisations out there that are already serving a purpose for people experiencing deprivation. And all we really did was piggybacked on those. So we're not trying to do it all by ourselves. That's completely impossible. But actually the added value that we could bring to these organisations as musculoskeletal experts was a massive offer for them. And vice versa, the intelligence and the access to people that we wanted to support, we wouldn't have been able to done it without their support. So it's building, it's adding and building and extending the already existing teams that are out there in these communities. I think that for us was a real success. And there are small things that can be done, I feel, that doesn't take a huge amount of resource and infrastructure as well. It seems quite overwhelming, but I don't think it necessarily needs to be when there are already people out there really fighting to tackle inequalities and poverty.
Value of the patient organisations in relation to MSK. But also, don't forget, as Anthony, use those links to help, so you don't have to do all the outreach to communities yourself. In fact, you're better off engaging with people who already have those links. So a theme coming through on the questions is around digital, and I know that we talked about in the report. So I don't know if any of the panels comment on this one, but how do you see digital as pertains around MSK Health? Anybody got any thoughts on that one?
So sorry, I missed that last bit of your question. What was that? What?
So can you see any opportunities or dangers in digital for worsening or improving health inequalities, where the digital fit into this inequalities debate?
Okay, I think I got it. It might be my link. It was a bit broken, but I'll have a look at looking in the questions. There was some questions around digital health and digital access for young people. We know that access to digital platforms for young people, as much as we might all think our children are constantly on tablets and games, actually lots of young people do not have access to good digital platforms, particularly for health and for education, and that was shown very clearly in COVID. So I think we have enormous opportunity with digital health platforms. If we get it right, then we will immediately address a lot of inequality of education around healthcare and empowerment for young people and older people alike. It's just trying to work out a way forward to make this as equitable and accessible for all. But goodness, the scope is enormous there.
And we got.
Hi there. I'd like to come in on this if that's okay. Hi, Wesley. I think I agree. I think there is a massive potential for digital to support here, but one of the observations I would make during COVID is that actually we really struggled for people who didn't have the up-to-date phones, who didn't have Wi-Fi or internet connectivity to be able to access healthcare through virtual consultations. That was was actually what I was looking at, virtual consultations for my PhD during COVID. And what I would say, through having spent a fair amount of time in food banks, what we actually found was that food banks were handing out data and phones for people to use, because to access services, you need to have a good enough phone, you need to have enough data, and there are some services that are online only. And the fact that they were handing out SIM cards and phones in food banks, because people just simply can't access digitally, there is a massive, I think we need to be really cautious and we need to be really careful, because the most deprived people that cannot afford to buy food, I would suggest, are probably going to struggle to be able to access, a phone that can deal with some of these apps and some of these things. And I think that's something that as a society we need to really look at. I think these apps work very well for people that can afford to access and use them, but I think that the focus of these conversations are around people that are experiencing deprivation and inequalities. And I think there's something to be said for finding ways to be able to be equitable with how people can access these sorts of things. So I think I'm a massive fan of digital. I think it has a huge amount of potential, but I think we need to be really careful and think very carefully about the use of digital for any aspect of healthcare, because if there's someone that can't use it or can't access it, then we are exacerbating those inequalities.
Just to put it in context as well, in COVID, it wasn't unusual for families with 4 or 5 children to be sharing one phone to try and access all their lessons online, and it was just awful. So I totally agree, Anthony, and it's something that doesn't work well at the moment, certainly for our community.
Yeah, I mean,
and I would say, oh, go on, Shabir.
Just to mention that I've had a similar experience locally with our GPs who switched to digital almost overnight, and I have elderly parents who are completely digitally illiterate generally as well, and they couldn't use the system, they couldn't access the appointments, and their justification for doing that was basically you need to get someone to do it for you. For me, it's very easy to do, and the appointment systems are better. But for people who have got language difficulties, who've got digital literacy issues, it's a massive problem that doesn't seem to be being addressed.
Yes, and I think that's a good point. That sometimes there's an assumption that the digital divide is about age, but as Jacqui says, there are younger people with significant challenges accessing digital. There are equally older people who are completely comfortable with it. But it seems to me, from all the evidence I've seen, that difference with the older group is around education level. So again, that is another big inequalities divide. So the older people in the more deprived areas are less likely to be able to access digital options than the older people in the less deprived areas. So there's a risk that the digital just exacerbates those inequalities, as Anthony says, even though it does potentially have quite a useful role to play in in the report, but would benefit from some of the messages. Are there plans to reach out? And the answer is yes. Yeah, I seem to have signal dropping out. Just 1 second. Getting rid of the virtual background helps. Can people hear me now? Has that helped? Yeah. Okay.
Yeah.
So the answer to that question is yes. Part of the project, this project from the very planning stages, was to make sure that this report was disseminated widely and that we promoted it as much as we could. So there always was what we're in now, which we call phase 2, which is the report is out there, but we're not stopping. We're doing events like this. We're going to be constantly trying to update our website with more good practice examples that people can learn from. We'll be doing more webinars on specific things that people say they want. Look out for us at various conferences throughout the year. We're also going to be doing launch events in Wales, Scotland, and Northern Ireland by the end of this year. So our general approach from the very start has been to make sure that this report gets as wide a reach as possible. My observation about the MSK community is there's a really high level of enthusiasm, despite all the challenges people face, to actually implementing this stuff. It's been incredible the way people have grabbed the report and said, yes, we need to do this, we need to respond to this, this is what we've been looking for, we need to discuss this. Now, obviously, that's not everybody. There will be services out there that are not so interested. And other than keep repeating to them, look, here's another example of a service like yours that's been able to do something. I'm not sure there's much we can do, but if any of you have audiences, newsletters, websites, anywhere that can just re-emphasize again the message that this report is out there, that these are important issues that need addressing, and whatever the challenge is, we all need to pull together to address those. So which is quite a good, we're coming towards the end of our time, and that's probably quite a good point to begin to wrap up, because I wanted to end by just reminding people of the most important finding from the report, which was the importance of not being overwhelmed by the size of the challenge, the importance of just deciding to act and to take one small step. So even if the work that Anthony did looks a bit too ambitious as a starting point for you, everybody will be able to think of one thing that they can start to do to try and address these issues. So I'm going to ask Kathy to put up one final poll, which is the question, how will you act now on MSK health inequalities? And just to reiterate, this is totally anonymous. We will not know who said what, so no one is going to hold you to account. So you can put your ambitious aims down if you wish. So I'll just give people a minute to have a think about what they might be able to practically do. Read the report. Actually, yes, that is a point that I've made a number of times. The report is quite long, and many of these long reports don't get read. But I have to say, the person who did the report writing did a spectacularly good job. And people have commented that it is readable and interesting and accessible. So I would absolutely recommend reading the full report, not just the summary, because Virginia did an amazing job on the writing of it. It's also full of links and resources and case studies. There's a huge range of different case studies in there, including Anthony's. So definitely, I would say read the report. Reach out to Anthony. Yes, I'm afraid you might be a little bit busy as a result of your appearance on this event. And then understand our community and find out why people don't access the services. Already been to meet the head teachers of the local high school, set up a collaboration. That's brilliant news. Increasing awareness. And yes, and share the report. Anything you can do to help us get that report out there and recommend it to others. Absolutely brilliant. So thank you very much for that. And Kathy, if you want to just stop sharing that. So I'd like to end by just thanking all of you for taking the time to join us today. And as I say, we will be sharing a link to the report. I'd like to thank Jacqui, Anthony and Shabir, not just for the time that they've taken today to join this webinar, but also for the different contributions that you made to this report and to making this report as strong as it is. So thank you all very much for joining us today, and please do keep in touch. And yes, we will keep doing a range of different informative sessions, as Mel has suggested. So thank you very much. And I'm just going to stop recording.